Sorry about everybody, let's go. So we're going to present the case from Santa Casa, São Paulo. Santa Casa is a hospital in downtown São Paulo. We are responsible for a population of 2 million people. We see 2,000 patients a year, 90% blunt, and we have 2% only gunshot wounds. It's not so frequent in São Paulo downtown. Let's start seeing this patient, but not at Santa Casa, but in a secondary hospital. We call, perhaps in the United States, you could see like a level 3 trauma center. You got operation room, you got general surgeon there, but you don't have sophisticated equipment. You don't have specialties there. So it's a 30-year-old male brought by the police without pre-hosp assessment, victim of 2 gunshot wounds. This one is the entrance and the back, 6 intercostal space, right side. It is just medial to the scapula, but no lateral to the spine. And there was another one here in the middle part of the thigh. Entrance is anterior, and you can palpate the projectile posteriorly here. The guy was talking, airways was clear, were cleared, respiratory rate was 24, saturation 96%, decreased breath sounds at right with no percussion. Heart rate was 100 with a skin perfusion. Okay, the perfusion was okay. There was no, the patient was not in shock. Blood perfusion is 110/60 with no external bleeding. The cardiac sounds were normal. There was no abdominal pain, neurologic intact, and we got these 2 gunshot wounds for us to assess. This is where we started the discussion.
Dr. Antrak, would you like to make any comment?
Sorry. So yes, so he needs 2 IVs, sample for blood. Although he's stable, the pulse is 100, and he could deteriorate at any time. My concern is that the thoracic wound, unless it went from posteromedial to anterolateral, it is if it had gone straight through, if there was an exit wound, it would be in the box. So you need to be concerned about the mediastinum, and then I suppose the pulmonary hilum, and then any other injury in the thorax. So my concern would be immediately chest X-ray, EFAST with attention to the pericardium, and he needs a chest tube on the right side. All those things in rapid order, and the next steps would depend on what the observations were after doing those things.
Thank you, Dr. Antrak. Dr. Baguazir.
When I was in Toronto, Dr. Rezendi taught me to do the primary and secondary survey. So I would do what he taught me there. As you can see, the primary survey is pretty obvious, it's pretty stable, but I would not rush it to give him any fluids or blood as of now. I agree with Dr. Antrak, he will need a stat chest X-ray to rule out hemopneumothorax on the left, and a stat EFAST to look at the pericardium and the abdomen as well. Yeah, that's what I would do at this time.
Thank you, Doctor.
Just to mention, there is another question in the chat. We didn't have FAST, so at this hospital, FAST was not available.
Perfect. Dr. Fraga, your comments, please.
The patient is stable. Do you have X-ray in this hospital?
Yes.
So I think it's important to have a chest X-ray, 2 position, lateral and anterior posterior view of the before I transfer the patient, because if the patient has a hemothorax, a pneumothorax, sometimes there's a delay to transfer the patient, 30 minutes to an hour. So I think it's very important to have the X-ray before. If you don't have the FAST, maybe transfer to another hospital to investigate about the pericardial effusion. If is there some effusion in the pericardium, it's very important to investigate. but start with the chest X-ray and give a fluid for the patient, a little amount of fluids, just to have a EV line to start to give fluid. The patient is stable, so you need to transfer to a hospital, a trauma center. Unfortunately, sometimes these patients with gunshot wounds go to a small hospital, and you don't have so much to do in a small hospital. Usually, you need to transfer to a trauma center. I think it is safer for the patient. Thank you.
Thank you, Dr. Fraga. Dr. Kasim, Portland.
Good morning. So this is a gunshot wound from the back. And I agree with Dr. Untrak. This one in the thorax is in the box till proven otherwise. And if it is truly in the box, which it is, then you need to somehow use your clinical acumen to see if he has any of the features of Beck's triad, if you don't have ultrasound and other modality of imaging available in this tertiary hospital, rural hospital rather. So look for clinical signs of jugular venous pressure, engorgement, narrowed pulse pressure, muffled heart sounds, etc., and document it. And then, of course, you look for any obvious bleeding, which this patient is not exhibiting, and you need to document the presence or absence of pedal pulses and femoral pulses on the right side. I think I would probably get a chest X-ray first and put a chest tube in and get him transported as quickly as possible, because this small hospital or rural hospital is not capable of taking care of this trauma patient at this moment. Thank you.
Thank you, Dr. Kasim. Dr. Burke, Iraq.
Yeah, I agree with Dr. Kasim. I'd be very, and Dr. Untrak, I'd be very worried that this guy's going to crash. But the chest X-ray, I'd probably get an abdominal film just to see if the bullet ended up in the abdomen.
Thank you, Dr. Resende. Your comments, please.
Yes, I think everybody pointed out all the aspects that need to be taken here. If there is no ultrasound in this hospital to do a quick FAST of the pericardium, then we'll have to rely on the chest X-ray. And if this patient is going to be transported, it might be advised to, useful to put a chest X-ray, a chest tube, regardless of what the chest X-ray shows in this patient. Otherwise, he could develop a pneumothorax on the transport.
Perfect, thank you. I think we have Dr. Ivaturi. Dr. Ivaturi, would you like to make any comment?
Yes, I agree with all the comments that have been made. And I think that it's very important that you consider this a thoracoabdominal wound. So I would get a quick chest X-ray, quick abdominal film, see if the bullet is in the abdomen, put a quick right chest tube in, and then transfer the patient. Thank you.
Thank you, Doctor. Dr. Parreira, we go back to you.
Okay, we thought, well, it was not our team that was responsible for this first treatment, but we agree with all the comments. He was offered oxygen by mask, X-ray to decide the next step. Here's a very good comment. I think that this is not a way this patient is not going to need a chest tube. He has a very clear alteration physical examination. So I put directly the chest tube and see what happens. And then after this, I'll do the X-ray. But the personnel in the first hospital, they decided to wait for the X-ray. IV lines, no big amounts of fluid, exams, type, blood for type and cross match, and was the fast was not available. And the X-ray was not only the chest, but abdomen and the thigh too. Okay, and the secondary survey, what we saw ample, we didn't see many things. The mechanism was already described. There was no alterations in the head, neck. Chest kept the alteration in the breath sounds with normal cardiac sounds. No pain, no signs of peritonitis in the abdomen, but the extremities showed a decreased right distal perfusion. So there was a decreased distal pulses on the leg that was injured. Here you see the first X-rays. Comments?
Dr. Resende, Neto, would you like to make any comment?
Now, on the chest X-ray, it seems that there is some hemothorax on the right side, possibly some pneumothorax as well. I can't see very well. So the chest tube is indicated on this guy.
Perfect. Thank you, Doctor. Dr. Kasim, Portland?
I agree with the doctor.
All right. Dr. Antrak, any other comment?
You're muted.
Yes, I agree with the others. Chest X-ray, regardless, before transfer on that side. And the thigh, it's something. If he's not actively bleeding and he doesn't need a tourniquet, that could be the perfusion could be evaluated at the other hospital.
Thank you, Doctor. Dr. Fraga, any comments?
I agree. Put a chest tube on the right and transfer the patient.
Thank you, Doctor. Dr. Burke, any comments?
Is this an upright chest X-ray or is he lying flat?
He's lying flat. It's just AP, anterior posterior.
Yeah. Yeah, I mean, I'd put a chest, it looks like he's got a hemothorax on the right. I mean, I'd put a chest tube in as well. I don't see the bullet.
Yeah.
And that
this is the first thing I
concerns me.
thought too. Where is the bullet?
I guess I would, he sounds like he's reasonably stable. I would be looking at the pelvis and the neck.
Yeah, I'm showing the next films for you.
Okay, we have
So
also
this is the first
Dr. Bawasir, any comments? Sorry.
Yeah.
No, I agree with everyone else. Or I would put a chest tube on the right side.
Okay, thank you. Dr. Parreira, we'll back to you.
Oh,
Dr. Parreira, just a question. Can you go to the next X-ray?
Yes.
There are two bullets. Yes, this one, maybe the infrascapular can go to the pelvis. And there is another bullet on the right side. Yes. So did you examine the patients? No bullet palpable on the soft tissue. No signs of
Gustavo,
bullet.
there was a clear tract. There was a gunshot wound in the medial part of the thigh. And probably this is the same bullet you palpate in the back. You can palpate in the back part of the thigh. And there was another one in this position here. Yeah, this position here.
Okay. And in the neck, no bullet in the neck because
No neck.
Bullet?
No
bullet in the neck. Okay.
Any comments? There is a question from Luciano Tastaldi, he's a very good surgeon in abdominal wall and laparoscopic surgery. Luciano, can you rephrase your question here? Are you asking for the distal pulses on the right? Yeah, there was no pulses on the right below the popliteal. Are no pulses at all.
Yep, that was my question, sir. Thank you.
So one more comment I'd like to make, that after you put the chest tube in, and knowing that the patient has bullets in the thigh, absent distant pulses, please make a note of it what time that you determine that, so you know exactly the patient, what time the patient arrived, what time the clinical examination was done, and the absence of pulse was noted at such and such time, so you know for the future how long you can play around with it before you do something definite to restore the circulation. Thank you.
Yeah. Any other comments? Dr. Vaturi? I think Valeria hasn't asked him.
Dr. Parreira?
No, I agree. I agree with all the comments that have been made. Very good comment by Dr. Kasim. So there are no distal pulses. Obviously, he's got probably a femoral artery injury in the mid thigh. He said there's a clear tract palpable. Was there a lot of bleeding at that point from this side? And are there any abdominal signs? What are the vital signs? So everything would depend on how the patient is doing at the moment before you do anything definitive treatment. I see an area of lung contusion on the right chest. We don't see a chest tube, so I think we need to put the chest tube in and tell us what's happening with the hemothorax on the right. How much is the tube draining, etc.
Okay.
Thank you, Gustavo.
You're welcome. Dr. Vaturi, we have here a comment about 2 bullets and very good comments. Dr. Ilya Shadyan, to everyone, said bullet embolism, bullet embolism. I'm not sure Ilya can explain to us what you were thinking about bullet embolism.
Yeah, usually it's smaller vessels, but smaller bullets, I mean, but you can have a bullet enter the bloodstream and actually travel distally.
Well, good. Let's see.
Dr. Parreira, the patient has abdominal pain or
no abdominal pain, Gustavo. No abdominal pain. The question was, should we open the abdomen thinking in transabdominal trajectory? So probably an abdominal injury. You could do a laparotomy in this hospital if you wanted, but the patient was not really no abdominal symptoms of peritonitis, nothing.
So I think the suspicion of bullet embolism is totally correct, because no abdominal pain, you have the projectile in the pelvis, and the bullet's not in the chest. Probably it's at the iliac artery. Maybe let's see.
Yeah, you know, we had another projectile here in the thigh, and it was in the same, you know, trajectory of the arterial or the femoral arterial. So I'm not sure what we're gonna do here, but I just ask you, we had no vascular surgery in this hospital. If you were there on call, would you do something before transferring this patient? I mean, what they do, chest tube with the initial 600 milliliters of blood, but progressively a decrease in the output, and the patient remained hemodynamically stable with no abdominal pain. There was no CAT scan, but there was an abdominal ultrasound, which perhaps for people that is not from the Latin America, here we had the radiologist trained to perform a complete abdominal examination with ultrasound. So you can see the liver, the spleen, vessels, and everything else. But we do not have the equipment in the ER. So we can do an abdominal ultrasound, can ask for a radiologist to do it, but we do not have the equipment in the OR or the ER to do the FAST. And then that's what they did. I would ask, would you think it can, because you know, in Brazil, sometimes the time to transfer is really difficult. And this patient experienced exactly this. The time for transferring was really expected to be high. Would you do anything trying to improve the circulation and the leg would you thinking do a laparoscopy to exclude peritoneal penetration? I'd like to see your comments.
Dr. Fraga, your comments?
I think CT, CAT scan is very important for this case. Nope.
No, at this hospital, we didn't have the information. Yeah.
So I think you need to transfer the patient because the patient is stable. You don't have the equipment to investigate the case. You need a vascular surgeon you don't have in the hospital. I don't know if the surgeon that was in this small hospital is very skilled to treat a vascular injury. So I think it's better transfer the patient at this moment to investigate where is the bullet, what kind of injuries the patient has. Only 600 of blood on the chest, on the right. So I think it's possible to transfer. How long do you think it will take to transfer this patient? 1 hour, 2 hours?
No, more.
More?
We were more than 10 years ago, and the system was not that fast, especially because this hospital have a general surgeon that was supposed to treat such patients. So it's very difficult to say how long will it take to transfer. I'm not sure if Dr. Rezende, who worked here in Brazil and had this experience in Isoleta Neves, how long perhaps you have a hospital. It's not a level 1 trauma center, but you actually don't have all the material equipment you need. So it's very difficult to transfer in our reality. Nowadays it's better. Currently you have a better system, but that time it was very difficult.
Okay. You were asking me a question?
Yes. What are your experience in Isoleta Neves? Did you have all specialties there?
Yeah. So that was a trauma center that I considered level 1 based on American standards. The only thing we didn't do was research, but we treated patients all the time, and we had
all specialties.
Everything. Okay. Trauma surgeons do everything.
Yeah. That's why I need trauma surgeons. Let's go.
All right, Dr. Untak, your comments?
Yeah, so given that you couldn't transfer the patient rapidly enough, so basically transfer not available within the requisite time frame, and that you had a fully trained radiologist who can do sonography and an ultrasound machine, and the patient is at this point stable, then you need to try to do damage control to anything that would not survive the transfer when it could occur. So I would ask the radiologist, and probably 10 years ago, they wouldn't want to do this, to wheel down his ultrasound machine. If not, the patient's stable, I'd go with the patient to the ultrasound, to the radiology suite, and ask the radiologist to do an echocardiogram and basically a fast, the equivalent of a fast exam of the abdomen, or any abdominal exam that he did would give that information, and then also a vascular exam of the common femoral, superficial femoral, and see what the status of the and the veins, to see the status in the leg, and then talk with the general surgeon if the patient had a complete occlusion of the SFA. I would hope that they'd have shunts, and they can put a shunt in, and reestablish perfusion, and then worry about the reconstruction on transfer, which can wait, a full 24 hours or so, for as long as it takes to transfer the patient. And so you'd be able to rule out intrapericardial injury, anything that might. It sounds like the right hemithorax is okay. If there's an initial collection of blood, no ongoing bleeding, that's okay. And the examination of the abdomen by sonography would indicate whether you had the perforation or any bleeding from the trajectory of the bullet. But I think at this point, all you have is a good radiologist and an ultrasound machine. You need to try to figure out what what you would talk to the general surgeon at this small hospital about doing for the patient before transfer.
Thank you, Dr. Antrak. Dr. Kasim, your comments, please.
So in a situation like this where CT is not available and you have a radiologist who can do ultrasound, I agree with Dr. Untrak again that I would beg him to do an ultrasound of the leg to see what the vascular status is. And if he is not successful in telling you what you want to hear, or he's not going to do it for you. And then the alternative is you have stabilized his chest injury by putting a chest tube, and you got 600 cc of blood, and there is no further bleeding episode from the chest. And if he is relatively stable, it is quite easy to take him to the X-ray department and do one single film. Put a cassette under the thigh and then put a needle into the femoral artery and then inject some dye and get one film. And at least you will get some idea what's happening to the femoral popliteal, the three tributaries that supply the leg. And you have some, at least you get one film, and that's all you will get. And in fact, I have done this, and I did this in Guatemala many years ago, when there was nothing available, and we were able to get the answer what we wanted and fix the problem. That's one way of treating it. Thank you.
Thank you, Dr. Kasim. Dr. Bawasir?
Well, I agree with everything that's said. The patient needs to go to a trauma center where he needs to have a CT scan and exploration of the leg. However, because CT is not available at this time, and as a trauma surgeon is there, is it easier to transfer the patient or bring the trauma surgeon to the center? I agree with Dr. Antrak. Putting a shunt is a very good thing. Shunt has been shown that it decreases rate of amputation, decreases rate of fasciotomies as well. So shunt is the best thing to do for this patient if anyone capable of doing that before transferring the patient to a trauma center. Thank you.
Thank you. Dr. Burke, your comments, please.
So if I'm understanding this correctly, the chest tube was put in, 600 cc came out. I'm assuming there wasn't a huge air leak. And then there's 2 bullets in the right leg, one in the mid-thigh and one in the femoral region.
Pardon, just one wound in the thigh, just one wound. And you see in the X-ray of the thigh, 1 bullet. When you go above for a while, you see another bullet on the pelvis.
And you could feel a bullet on exam?
Exactly.
So the upper bullet is the one you can feel?
The upper bullet, I'm sure I'm going to answer your question a bit later. So there are two gunshot wounds, one in the chest, posterior, and one in the thigh. And there are 2 bullets. 2 bullets are one in the middle part of the thigh, another one in the pelvis.
All right. So it's not clear to me which bullet is
the responsible for the probable arterial injury may be two possibilities.
Right. It sounds like the chest. I mean, it sounds like the chest situation is stable in terms of you don't need to explore the chest. It sounds like his belly's benign, at least for now, and it sounds like you can't transfer him, and he's the clock's ticking on his leg. So I would take him to the OR, and I'd do an angiogram on the table from his femoral artery and try and figure out is it a bullet embolus? Is it the bullet mid thigh that's knocked off his SFA? And then you know, fix or put a shunt in like Dr. Untrack suggested. You know, if you can't fix it, if you can't put in a vein graft, then you know, do the bypass and do fasciotomies and hopefully save his
Fasciotomies,
leg.
that's what I was asking you. What do you think about fasciotomies for this guy?
I would probably do fasciotomies. You know, again, I do the first part right now is figuring out what's going on with his arterial supply, and then once you figured that out, I would finish up with the fasciotomies, just because his leg has been ischemic for a while.
Yeah. No, this discussion is so important because in Brazil, we are not in a war situation, but we sometimes do not have all the equipment and resources we have. And the timing for transfer is not, you can trust the patient will be in a better hospital, in an equivalent hospital for level 1 trauma center in some hours. You can bet to be there. So we have to be prepared to work with these small amount of limited resources situations. Yeah? In times of war, I believe it's very important because you have to solve the problem. And let me go ahead because we have
Dr. Resendenet and Dr. Ivaturi would like to make comments.
Whoa, Dr. Resendenet, Dr. Ivaturi, they speak whenever they want.
Go ahead, Al.
Thank you very much, Raul. So the comment that I wanted to make is, if this guy has no peritoneal signs, and I mean, if there's a bullet in there in 2 holes, either the bullet in the thigh went in through the same hole as the other bullet, so both of them in the same hole, or the bullet from the chest came down to the thigh, or one of the bullets went up and the chest wound is an exit wound. Nonetheless, if this patient has no peritoneal signs at this time, and it seems that time is passing by, and he's stable, when I looked at that x-ray, I saw that the bullet is a very low caliber, one of those bullets. And we've had patients that those bullets have very difficult, they're not easy, they don't penetrate very easily, and they can go through the trajectory of the extraperitoneal space or the retroperitoneal space between the fat tissue and muscle, and then find themselves very remote from the area where they penetrated. So that little bullet there on that pelvis, or could be a 22 gauge, maybe, I'm not sure, caliber. And sometimes these bullets do have this trajectory. So that's something to be mindful of. And regarding the leg, I mean, if the surgeon can do procedure to correct the femoral artery, then he does it. Otherwise, they could put a shunt in and tie the shunt off and then transfer the patient for reconstruction if the surgeon is unable to do that. So you can do a temporary shunt with a latex tube, tie both ends, and send to the definitive treatment if it's going to take too long. Thank you. Raul.
Thank you. All excellent comments. There is nothing much left for me to say except that Gustavo has been avoiding my question all the time. I asked him whether there was a big hematoma in the thigh. There was a lot of bleeding from the thigh wound.
No.
Nothing at all.
No,
so
no, sir. No, sir.
So the chances are that the superficial femoral artery is not injured in the thigh, and this bullet is just a red herring. So I think the money lies in the pelvic bullet. Where did this bullet come from? So I think the embolization was a very good thought. It's very possible that this bullet went retroperitoneal, got the iliac artery, and then embolized distally, blocked out the blood supply to the extremity. And so we don't have any pulses, in spite of the fact that there is no big hematomas, etc., in that limb. So as was pointed out, the radiologist can do a quick ultrasound, tell us if there's a big retroperitoneal hematoma. If there is one, now having known the Brazilian surgeons, having worked with them I know they're superlative technicians. So even a general Brazilian surgeon can take this patient to the operating room, explore the retroperitoneal hematoma, control the bleeding from what possibly may be external iliac artery injury. If he can repair it, he can repair it. If he cannot, then he can either do a shunt there and do a quick angiogram if he wants to. Otherwise, control the bleeding, put the shunt in distally, and then transfer the patient to the remote trauma center, which you told us is about 10 hours away. But as long as you have controlled the bleeding, restore the perfusion, now you are not behind the clock, you're ahead of the game. So all of these, I know the Brazilian general surgeons can do. So that would be my approach. Thank you, very interesting.
Thank you, very good comments. Well, let me continue here. Well, admission at Santa Casa, 36 hours or more. I cannot really express exactly how long it took, but it was more than 2 days, 1 day, certainly. The guy remained conscious, Glasgow Coma Scale 15, hemodynamically stable. There was a small amount of blood in the chest tube. The chest, well, there was still a decreased breath sounds on the right side. No alterations in cardiac wounds. The cardiac sounds. Abdomen was intact, no pain, no signs of peritonitis. And the right leg showed a decreased distal perfusion, and there was a right foot and leg pain at the right foot and leg, decreased pulses from popliteal, decreased but not absent, decreased but not absent pulses in the popliteal and below arteries. There was paresthesia, the right hallux, and by the Doppler flow on the ER, they found, the vascular surgeons found a flow. Yeah, I'll put this together. Just let me. This is the X-ray at Santa Casa. See the chest tube is well located. There was not much blood here, perhaps a lung contusion up here. We call for the vascular team. They asked for angiography. We, as a trauma team, we asked for the CAT scan and the echocardiography, as it was mentioned before. Take a look. This is very interesting images. Here you see the entrance of the bullet. You will see a fracture in the rib and then a contusion in lung. Here again. And you see here the fracture, the rib fracture, and then the contusion is very limited here, and then it just disappears. There was a normal echocardiogram, and not just a FAST, but an echocardiography performed by the cardiologist. So it's completely normal. No thrombos, no intra-atrial or intraventricular thrombos. We thought that could have perhaps a cardiac injury to the, for example, left atrium. But it seems that the bullet went through the left pulmonary vein into the cardiac and the heart. Then there was a normal CAT scan of abdomen and pelvis. I can show you 2 films here. There was no blood, no liver injury, no, Dr. Vaturi, no retroperitoneal hematoma at all. It was a completely normal CAT scan. The vascular surgeons decided to perform the angiography, and this is a matter of discussion why to perform angiography if you have a have a major signs of ischemia in the leg. What they say, I'm just looking at if the people from our vascular team, Santa Casa, they actually were, I invited them to participate here, but I'm not recognizing them in the list. So if there is someone here that would like to comment on from Santa Casa vascular surgeons, please raise your hand. but I can find them here. They decided to de-angio because, see, you had two bullets here. One, this is the minor one, is the tied, the wound, the bullet that went from the gunshot wound in the thigh. And there is another one clearly inside the femoral artery, clearly the superficial femoral artery. Yeah, you can see this here. Well, let's ask what is the next step for the panelists. What do you do?
Dr. Resendeneto?
So if the vascular surgeon is there, this would be a vascular case, like you said, or a trauma surgeon that does vascular procedures, and that patient will require a repair of that artery and removal of that bullet, and fasciotomies.
Thank you, Doctor. Dr. Burke, your comments, please.
João, what about the entrance wound? Would you be worried about correcting the injury in the thorax or not?
Yeah, so I think that when you repair this, I still think that if this patient came, if this bullet came through the heart, obviously you'd have your CT chest or your echocardiogram showing some abnormality, right? So if it didn't go through the heart, it probably could have gone through some major pulmonary vessel through the parenchyma of the lung. And if the lung has stopped bleeding, then I'm not really concerned about it because there is no more blood in the chest. So, I mean, I wouldn't be opening the chest and to assess this. The only thing would be over there close to the groin, maybe laparotomy with exploration of the inguinal region there without cutting the inguinal ligament would allow you to have proximal control of this vessel, and then you have to have distal control as well. But in the chest, I can't explain this very well from what the findings that you give me. So it could be that it went through the lung parenchyma and then found a major vessel and it went down. I'm not sure.
Yeah.
Thank you, Doctor. Dr. Burke, your comments, please.
Yeah, so again, I'm assuming there was no tract seen, between the lung and this area. So I'm assuming it's a bullet embolus. Was any air leak? Just out of curiosity, any air leak at all?
No, Dr. Burke.
All right, so I'm less concerned about how it got there in terms of the lung. I agree completely with Dr. Neto. There's no bleeding, the lungs inflated, there's no air leak. I'd just take care of the problem, and that's the bullet that's sitting there. I'm assuming it's just one view, but that's sitting at looks like the profunda and the SFA. And I think I'd be focused on taking that out and then doing the fasciotomies. At 36 hours, he's had an partially ischemic lower leg for a while.
Thank you, Dr. Burke. Dr. Kasim, your comments, please.
First of all, a single view like this is not good enough for you to accept it and take the patient to the operating room. You need to get a second view, which is lateral. This bullet may be sitting on top of the femoral artery or femoral vein, may not be in the lumen itself. I mean, if you look at the contrast flow in the femoral artery, the flow looks pretty good to me.
Yes.
So I'm not 100% convinced this bullet is in the femoral artery. It may be in the femoral vein, or it may be on top of it. Get a lateral view before you do anything. Okay, suppose you find this bullet is sitting in one of the vessels, either it's a femoral vein, femoral artery, and then it behooves you to go and fix it without wasting any more time. You don't have to be Sherlock Holmes to find out where it came from, because what is causing this patient's problem is ischemia of the right leg. Whatever is happening in the chest, it's happened you don't have to hypothesize where it came from, etc. at this moment. That is for another day. Go and fix it. And like Dr. Burke says, this patient has been suffering from ischemia of the right leg for considerable amount of time, more than 6 hours, and he's already showing some paresthesia of the hallux valgus. And I think he is in danger of getting compartment syndrome. So it is almost mandatory that you do superficial and deep fasciotomy.
Thank you, Dr. Kasim. Dr. Bagwasir, Boston.
Yeah. So in the United States, probably in Canada too, if we send the patient to CT and we suspect a vascular injury, we do CT chest, abdomen, pelvis, and at the same time we do CT runoff for the lower legs at the same time, just to save the patient going to the angio suite to do conventional angiography. With CT runoff, we're going to give you a lot of information about the extent of the vascular injury and about the distal perfusion as well. If you're happy with this view, I agree with Dr. Kasim. One view is not enough. I'm not sure about the distal perfusion and below what's going on below the knee. If the vascular injury is confirmed on CT angio and there's no perfusion distally, patient needs to go to the operating room for vascular repair. And I would not do anything for the chest or abdomen, as the CT abdomen is normal and the chest is can be managed non-operatively. Thank you.
Thank you, Dr. Fraga, your comments?
Well, I agree to have inguinal access to remove the bullet. And about the chest, no air leak, no leak, no bleeding, just
nothing at all.
Observe. Just
No
observe.
blood.
I suggest just observe the probably 2 days later. There was an injury. We don't know in the vessel or not, but if not repercussion, I just observed that. And I think fasciotomy will be necessary too in this case. Okay. After 2 days, probably fasciotomy early will be better for improve the perfusion of the leg. Thank you.
Thank you, Dr. Fraga. Dr. Antrak, your comments?
Yeah, yes, I had the same concerns that Dr. Kasim mentioned. You have overlapping shadows, and the shadow of the bullet is outside the shadow of the SFA, and then I don't see where the catheter is. Oh, I guess that's it. It went through the left groin, then up
Yes.
around the bifurcation, and then down.
Yes.
Okay, I see it there. So, and there is contrast getting beyond the bullet into the leg. So I would have the same concern. And so I assume you have lateral views, and so you know
Yes.
it's and I saw the following slide to confirm it. But so the only comment I have to add is that the leg was pretty ischemic at the other centers now, 36 hours, and that is something that I think in retrospect, had this happened today and you couldn't transfer the patient, but you could do the ultrasound, that's something the radiologist could have told the general surgeon. And I think any general surgeon can take care of that, to expose the SFA in the groin and do remove the bullet right there. You don't need any embolectomy catheters, assuming this flow. Well, you should have them just to establish flow if it's not there afterwards. But you can certainly take out the bullet and then close the vessel, and then if the surgeon couldn't close the vessel but he had a shunt, you could shunt in and transfer the patient, and then save about 30 hours of ischemia time on the leg, and then worry about the fasciotomies at the receiving hospital. I think you should probably do them there before transfer anyway. I think that's a good idea, but certainly that would probably be better taken care of at the original facility.
Thank you, Dr. Antrak. Dr. Ivaturi, your comments?
Yes, I think all the excellent comments. I think all these speakers have given excellent ideas for the junior surgeons to think about in this perplexing case, but every one of them is a pearl of wisdom there. So I would like to point out that Dr. Yontrak is very, very correct that this could have been done at the outside hospital. It didn't have to wait for a transfer to the definite trauma center, because the general surgeons, as I said, are very, very versatile, and they could have approached this. Once they have established there is no significant bleeding from the chest or the abdomen that you really need to worry about, then they could have explored the femoral artery and taken out any of these possibilities that were mentioned, like fixing it or controlling the bleeding and then controlling the injury with a shunt, transferring the patient. That would have avoided a significant amount of ischemia to the lower limb. Fasciotomies were important, very, very important. They could have been done at the primary hospital itself before transfer. So this could have been done a little bit differently instead of waiting for 36 hours for this whole thing to evolve. But once it's over, 36 hours are over, I think right now it's very clear. You go back to the x-rays, do a 3D reconstruction, see what exactly is the injury, make sure you have an arterial injury, and then approach it locally. And I think most likely the bullet went through the pulmonary vein, went through the left side of the heart, and then embolized to the distal vessel. That's one possibility. And if that is established, then you could actually do a distal exposure of the femoral artery and do an embolectomy and restore the perfusion. So those are some of the other options. Very interesting, Gustavo. Very nice case.
Thank you. Shall we go? Shall we continue, Valeria?
Yes, go ahead, doctor. We went over.
Okay. So they decided the approach directly. Of course, Dr. Cassin was completely correct. There was many other views, and I apologize, I didn't got it. You know, this is a very old case, and now I can say to you that some of these information we have to just get together from who treated the patient. It was a long time ago, so we actually kind of put together, because I think it's very important to comment exactly what Dr. Ivatur said. We sometimes do not have the ideal conditions to treat the patient, but we have to have these principles of damage control, and we have to apply them. As a surgeon, as a general surgeon, I have to be capable of putting a shunt in an artery, doing a fasciotomy, and transferring the patient. If you don't do this for a patient like this, the patient will develop perhaps severe ischemia, lose the leg, perhaps even the life. So it's important here, and that's why I kind of make an effort to put together this case and we bring it here for you to comment on. So this is the right groin. This is the femoral artery. Proximal control here, distal control here. Here is the opening of the artery longitudinally with the bullet inside. They removed the bullet, performed an embolectomy distally and to the profunda together, and they just use the vein graft to repair the artery. Yeah, it's a saphenous vein graft. Didn't say that, didn't I say it's a saphenous vein graft here, the right side. Yeah, it's a not a small defect, you see. So there was intimal flaps inside and injury, so they decided to substitute the artery. This is the angio after the corrections, showing a perfusion. They also perform a fasciotomy, 4-compartment fasciotomy, and the patient went well. We chose not to do anything in the chest. The echocardiography was normal, as Dr. Rezendi said. We thought probably the blood go through a right pulmonary vein inside the pulmonary parenchyma and direct to the left atrium, left ventricle, and to the aorta down there. we decided for non-operative treatment. We, of course, we managed to see this patient for a while and repeat the echocardiography later to see there was not any other thrombus or anything like that. The patient was well, is a young guy. This is one of the last pictures of the fasciotomy. That's the one I could get. That's it. I think I'd like to thank you all for the comments. And I don't know, perhaps you can see we are really 4 minutes gone for 2 o'clock here in São Paulo. Valeria, please.
Yes, go ahead. We'll do final comments briefly.
Okay.
Dr. Kasim, any final comment?
I'm not sure that you need a vein graft to this. That adds quite a bit of time. I think under the circumstances, I mean, you can argue about success, okay? You know, if everything went fine, you're okay. When you are faced with a situation where the patient has been ischemic for a long time, I'm just wondering whether if you are not better off going with what Dr. Untrak suggested, put a shunt in and come back later on. I would be very interested in to know what Professor Iventuri says to us, because he's a world expert on trauma care. Thank you.
You, Dr. Kasim. Dr. Fraga, final comments, please.
Congratulations, Dr. Parreira, excellent case. I think you have a lesson for this case. It's an old case, many years ago, but I'm not sure if in the last 10 years, we improved a lot the system in Brazil, the trauma system. So I think you need to do this, improve the system, transfer the patient when necessary very quickly, because 36 hours to treat this patient is something like unbelievable. So it's a problem that you have in our country, and you need to work hard to improve this. Congratulations, excellent case.
Thank you, Dr. Fraga. Dr. Untrak?
Let me just remember, Gustavo. Gustavo, I'm not sure you remember the Congress 2008, Pan American Trauma Congress 2008 Campinas. If I am correct, you and me, we were discussing a case with Dr. Morales from Colombia. And I'm not sure it's your case or his case from a bullet that went up and down inside the vena cava. Did you remember? Do you remember that or not? I believe it's your case.
Yes.
Morales was discussing. Yeah.
Yes, we had a case, the cava vein, the bullet. So the Trendelenburg position at the X-ray was very important too, because the bullet was moving in different position. It's not frequent case like this one, but a good trauma surgeon, I think, all in the conference suspect of the embolism. Someone wrote in the chat about embolism. So you need to think about this. But this is not difficult to solve. The problem is 36 hours to transfer a patient in the city of São Paulo, a big city, a lot of research. I think it's a little better nowadays. Not too much, a little bit. But excellent case, very, very illustrative. Thank you for presenting, sharing with us.
Thank you. I think it's a case that you see one, you never forget.
Thank you. Dr. Untrak, your comments, please.
Yes, what a great case. I mean, really a lot of good points for learning. And the patient was incredibly lucky. Not only did he keep his leg, but he could have had one hell of a stroke. Wow. You know, lucky where the bullet went. He didn't lose any bowel, and it just went down to the leg, and he just, you know, he could stick it out for 36 hours. Good for him. So, and very, very good teaching case. Just superb. Thank you for the presentation.
Thank you, Dr. Untrak. Dr. Bawasir, your comments?
Thank you, Dr. Parreira, for sharing this case. I learned a lot from the expert panel today and from this case in particular. Very impressive results. Thank you so much for sharing this. Patient is lucky because he survived and he had lots of collaterals. That's why probably his leg was saved and not get amputated after 36 hours of vascular injury. Very impressive results. Thank you so much again for sharing.
Thank you, Dr. Bawasir. Dr. Burke?
A very cool case and a very nice presentation. Thanks for taking the time to go back and look at all those details. I mean, you have all the pictures, x-rays. That took a lot of time, I'm sure. And I don't know who pointed out the bullet embolism first, but I think it was Dr. Bawasir. Whatever.
Yeah.
Someone
Dr.
out there,
Schneidman.
someone out there
Dr.
was very
Schneidman.
sharp. Who was that?
Dr. Schneidman from New York, upstate New York. If he's,
Yeah,
I don't know
well,
if he's still
someone
there.
picked that up right away. So very sharp.
Yeah.
Thank you, Doctor. Dr. Resende, your comments?
Yeah, very good case, Parreira. Just one thing, Sao Paulo has the largest number of helicopters in the Western Hemisphere, if I'm not mistaken. I think it surpassed New York City. And it's a shame that a trauma patient stays 36 hours in a different hospital before he can get treatment. And this is not in 2022. This was 10 years ago. Sao Paulo had already the largest number of helicopters. So this is a lesson to the healthcare people who make their who decide where the resources will go for them to kind of see this and change their policy. Good job.
Thank you, João.
Thank you. Dr. Ivaturi, your comments, please.
Yeah, thank you, Gustavo. Great case. We learned a lot of things from there. And I would like to congratulate you for an excellent presentation. And also for everybody for their incisive comments. And Dr. Kasim has always been very kind to me and very generous with his comments about me. I appreciate that. I would like to point out, though, these things happen even in Richmond and even in New York. So it's not unusual that some patients drop through the cracks. I always felt that it's very important that we in the level 1 trauma centers should really be all the time in communication with our level 3s or the lower level trauma centers around your catchment area. You must have an ongoing conversation about these cases going. And you should always encourage them to lift up the phone and talk to you and establish a relatively faster course of action than 36 hours. And so the communication is extremely important. And I hope that you do that as a routine, Gustavo. I appreciate your excellent presentation and also your leadership in taking care of these cases and bringing them to these conferences. We all learn a lot from them. Thank you so much.
Thank you, Dr. Ivaturi. Thank you, Dr. Parreira, for the
Thank
presentation
you.
and all
Thank
the
you all.
panelists.
Dr. Vaturi, thank you very much for your words. I think it's actually, we're following your steps. We're responsible here.
Thank you.
all.
Thank you, everyone. Dr. Martos joined, but he's in trauma call today, so probably he got called because I don't see him on the list. So thank you, everyone, and we hope to see you next week.
See you. See you later.
Bye.
Bye.
Bye.